Welcome to the Monument Health Cancer Care Institute's Oncology Clinical Pearl Sessions. I'm your host, Nathan Matlock. I am the current PGY2 Oncology Pharmacy resident at Monument Health Rapid City Hospital Cancer Care Institute. And today we're going to talk about hypersensitivity and infusion reactions. So let's get at it. So just a little bit of background on hypersensitivity and infusion reactions. Infusion reactions commonly occur with several of our anti-cancer agents. And so severity of these reactions, they can actually range from a mild flushing to all the way up to anaphylaxis or even death. The onset of these reactions typically are fairly predictable, but hypersensitivity reactions are unpredictable and can occur at any time. So while the exact mechanism of hypersensitivity reactions to chemotherapy are unknown and do vary depending on the agent as well as the individual, majority of these patients present with an IgE mediated reaction. Not all are the true type 1 reactions and may constitute an anaphylactoid reaction. So these reactions, like I said, typically IgE mediated. These are immunoglobulin, and these things they're key to a healthy immune system. We'll see here in a picture on the next slide, but they're produced by the plasma cells in response to a bacteria, a virus, or any other miscellaneous exposures that are recognized as non-self. We are composed or do have 5 classes. You have IgM, IgG, IgA, IgD, and IgE. So big thing to remember here is the first time a person is infected or otherwise exposed to an antigen, so a foreign non-self substance, their immune system recognizes it as non-self and stimulates plasma cells to produce specific immunoglobulins or antibodies that bind to and neutralize the antigen. The antibodies remember these antigens for future encounters and allow for a rapid production of more antibodies. As I said on the last slide, I was going to show a picture. This is the B cell or plasma cell, and you can see if you take a look over on the right side where everything comes from. So if you have an allergen type reaction, it's going to be IgE. Then you got tumor, so you have a tumor antibody, so tumor antigen. And you can see kind of where all of these B cell lineage derives all of our immunoglobulins. So immunoglobulins as a whole, so IgM, that is produced as a body's first response to a new infection or to a new non-self antigen, and this provides a short-term protection. And then the increase, this will happen for several weeks, and the decline as it switches over to IgG and that production begins to ramp up. So looking at IgG, these are actually produced during an initial infection. So it rises again for a few weeks and then decreases and then stabilizes. They account for about 70 to 80% of all immunoglobulins in the blood. And so the body retains what you can consider a catalog that will be rapidly reproduced on a subsequent presentation of the antigen. The basis of, and this is the basis of long-term protection, vaccines work to add to this catalog. So it's giving us an immediate acute snapshot. We mount a response and then we save it. So the mother's IgG, they actually provide protection to the fetus during pregnancy and to the baby for during the first few months of life. So IgA, it composes about 15% of the total immunoglobulins, but is also found in the saliva, tears, respiratory and gastric secretions, as well as breast milk. This does work to provide protection against infection in the mucosal areas of the body. So thinking that respiratory tract, so your sinuses and your lungs, or the GI tract, your stomach and intestines, all which have those heavy mucosal areas. So these can be passed between mother and child during breastfeeding, and it helps develop that GI protection. So significant IgA is not produced in an infant until about 6 months of age. Then, of course, IgD, its role is actually not fully understood, and it is not typically monitored. Then that moves us into IgE. And looking at this one, it's associated with allergies, allergic diseases, and with parasitic infections is another important one to remember. So looking at our next slide, here this is an interesting little quick snapshot. it kind of shows you which one they all look like, whether they dimerize, how they function and work. But the big thing I want you to take away from this is this little body over on the right side. You can see peripherally IgG, IgM, IgE, IgD, peripheral. And then highlighted IgA, so mouth to anus, all the GI tract is going to be your IgA. So that's a quick and easy way to kind of remember that if you can think about IgA just starting in the mouth. So now we need to talk about types of reactions. So an infusion reaction, hypersensitivity reaction, and an anaphylactic reaction, or an anaphylactoid reaction. So infusion reaction is any adverse sign or symptom occurring during the infusion of a medication or within the first day of administration. So fairly quickly. Hypersensitivity reactions, an infusion reaction that occurs at doses normally tolerated by a patient and not consistent with known toxicity of the drug. So this would go beyond what we would expect to occur. And then your anaphylactoid, it resembles an anaphylaxis but arises from non-immunologic pathways. So thinking our cytokine release syndrome. So this is a good little chart. It tells us when anaphylaxis is likely to occur when any one of the following three criteria are met. So first, acute onset of an illness. So you're thinking minutes to several hours within involvement of the skin, mucosal tissue, or both. So kind of looking like generalized hives, pruritus, flushing or swollen lips, tongue, or the uvula. And it's at least one of the following. Respiratory compromise, so thinking dyspnea, wheezing, bronchospasm, stridor, and hypoxemia. Or reduced blood pressure or associated symptoms of in-organ function, so collapse, so the patient collapses, syncope, or incontinence. Number two, two or more of the following that occurs rapidly after exposure to a likely allergen for the patient. So thinking minutes to several hours on presentation. So this can have involvement of the skin, mucosal tissue again. You can have respiratory compromise, reduced blood pressure, or associated symptoms of end organ dysfunction. And then also we add in persistent GI symptoms. This can be abdominal cramping or pain, as well as nausea and vomiting. 3, reduced blood pressure after exposure to a known allergen for that patient, so minutes to several hours. Adults, you're thinking systolic blood pressure less than 90 milligrams per millimeters of mercury or greater than a 30% decrease in the systolic blood pressure. So this is a good little chart to have and think about. It's the Gell and Combs classification. So looking at it kind of like if we look at type 1, we can tell it's going to be most likely IgE mediated. It's going to be an immediate type hypersensitivity, and its onset's going to be minute to hours. So this repeated exposures to a medication results in sensitization or the production of drug-specific IgE antibodies. So you're typically thinking anaphylaxis with a type 1. So type 2, you're thinking IgG, IgM mediated. Onset can be variable. And then kind of what they're presenting, hemolytic anemia, thrombocytopenia, blood transfusion reactions can be associated here, and then neutropenia as well. Our type 3 onset is antigen antibody immune complex, and onset's a lot delayed. It's 1 to 3 weeks. So here you can see deposition of IgG bound to allergen into tissues, complement mediated. So thinking serum sickness, vasculitis, fever, rash, arthralgias, proteinuria, and then nephritis and pneumonia. So type 4, again, cell mediated or delayed hypersensitivity involving those T lymphocytes plus antigen release lymphokines. Onset about a week, midweek to a week, so 2 to 7 days. You're thinking T cells, and then you're going to think more along the lines of SJS, TEN, DRESS, dermatitis or contact dermatitis, and things like that. And we're thinking about these infusion reactions. It's important to remember how some of these monoclonal antibodies are being developed. Here you can see down at the bottom, x-axis, you have a high potential for immunogenicity and then a low on the right side. As the monoclonal is derived from murine or mice. It's 0% human composition, so you're highly likely to react here. And then when you get down to chimeric, you've got a little more human structure involved, about 65%. Humanized, you've got greater than 90% human structure. And then if you get down to the fully human, it's 100%. And what's interesting is when you look at these names, these break off. OMAB, you're thinking murine. Chimeric, XMAB, Zumab, UMAB. So just looking at the drug name, you can discern how likely someone is to possibly react to that specific agent. So things that we have to think about when we're administering agents and what the likelihood of someone reacting is. So they have risk factors. Things like that are route of administration, the rate of administration, concomitant medications or therapy, interval between treatments, prior exposure to agent or agents in the regimen, and then excipients of a medication preparation. So we're thinking about a patient, they've had a reaction. How do we know? What are they going to present like? Kind of four things that you can think about are mucocutaneous, circulatory, GI, and respiratory. So thinking about these, mucocutaneous, someone's going to be flushing, they're going to be itching, they're going to possibly have some angioedema. Circulatory infection or signs and symptoms could be syncopal episodes, hypotension, tachycardia, hypertension, and then GI symptoms. Again, thinking that abdominal cramping, diarrhea, nausea, vomiting. Then we move into respiratory. Patients that present with these, you're going to see things like a cough, nasal congestion, shortness of breath, chest tightness, wheezing, and hypoxia. So another thing to remember is that evaluation and diagnosis can actually be very difficult in a patient is receiving multiple medications, and even the malignancy itself can produce clinical symptoms. So this is a look at the CTCAE grading system, and you can see allergic reaction. I've underlined some of the things in red that I found most important. So if you look at like allergic reaction, grade 2, you're really starting to look at your oral intervention here. That's going to be more of your H2 antagonist and your corticosteroids, and possibly your H1 antagonist as well. Grade 3, you're starting to look at bronchospasms at this point, and hospitalization indicated for clinical sequelae. So anaphylaxis, you really start at grade 3, and this is where you're going to get, and if you see this, you're starting with your parenteral intervention. And then if you get into the infusion-related reaction, grade 1, we do not interrupt the infusion. It's not indicated. And then grade 2, you can interrupt but respond promptly to symptomatic treatment. So looking at those antihistamines, NSAIDs, narcotics, IV fluids, etc. And then grade 3, this is going to be prolonged. It's not rapidly responsive, and you're probably going to just interrupt this one as well at this point. So yeah, those are, and then of course we've got cytokine release syndrome here, and then serum sickness as well. So this chart came from the World Allergy Organization, or the WAO, and this is a grading system for systemic allergy reactions. So very similar to what we've seen previously. Grade 1, 2, 3 from the CTCAE. And kind of what we need to look for. So grade 4 here, anaphylaxis is probably the big point. Lower airway, severe bronchospasms, not responding or worsening in spite of treatment. So yeah, this kind of like gives you an idea of how to grade out what the patient may be experiencing. So how are we going to prevent this? Pre-medications and the rate are two big things that we can think about. So your pre-medications, acetaminophen, and histamine receptor antagonist. So you're thinking Benadryl, diphenhydramine, and then famotidine as well. Then of course you can do plus or minus corticosteroids. And then so your histamine receptor antagonist, it's used to proactively reduce the effects of histamine and one of the mediators released by mast cells when they do become activated. And then corticosteroids suppresses the activation of pro-inflammatory functions of many types of immune cells, although they cannot prevent the mast cell activation or anaphylaxis event. So aside from that, we've got rate. We can always slow the titration, drop the rate. So yeah, let's move on. So these the next two slides here are from, this one is from the Management of Cancer Care Ontario. and is looking at how we manage the anaphylaxis events, these hypersensitivities or infusion reactions, what we need to do. Again, you can look at, it's very similar and easy to break down, prompt recognition. What do we do? In this first box here on the left, stop the infusion, maintain IV access. Your ABCs, airway, breathing, circulation, determine, assess level of consciousness, vital signs, and of course, if the blood pressure is low, and then oxygen if needed. Get someone on board. Is anaphylaxis suspected? Yes or no? And then kind of what we do and to go through this. And it's very interesting to see the next slide. This came from the management of ESMO guidelines. So here again, very similar. It has the prompt recognition. You have graded out 1 or 2, 3 or 4, and then what you do for treatment, and if as they resolve, things like that. And I think the big take-home point I would like you to take home from this is that greater 1 or 2, you're going to stop or slow the infusion rate plus your symptomatic treatment. Grade 3 or 4, there is no slowing the treatment rate. You're going to stop treatment and you're going to start aggressive symptomatic therapy. So that, I know that was a quick one, but that brings us to questions. So if anyone does have a question, again, this is recorded, but reach out to me. My email is right here in matlock@monument.health. I will gladly answer your questions and get back to you. So please reach out if you have any questions, comments, or concerns. I did throw in references for you. So that's it for today. I appreciate y'all and look forward to seeing y'all the next time. And y'all have a good one.